Rafinha is the captain. Captain Rafinha here. Here.
Su seconda partita. यार corner फिर से बात करना नहीं पड़ा corner है good save by the goalkeeper I guess ठीक है takes a good corner Rafinha
Absolutely sparkling. His reflexes were ultra sharp. Too much on it and out of play. Coming into half time, leading and thinking they're pretty good. To step in there was more than necessary. This time, but I'm sure it'll go again. Was this one that's foul? What was close to barely a breath of wind, so the football has no excuses for not being at its very best, but teams I know are pumped for this. João Cancelo, forward it goes. Very good evening to you on what is pretty close to a match of great consequence and massive interest in these parts. Learning a better wind, so the football has no excuses for not being at its very best. This is the perfect all-round strike. between the sides, and the score is 1-0. Set high. It's good distance on it. Let it pass it. And over Lewandowski. That's all good. Saka. Gabriel Jesus. Gabriel Jesus! Paris Saint-Germain bouncing constantly, perhaps too patiently. Forward it goes. Paris Saint-Germain back again. Gabriel Jesus. Hakimi. Hakimi. Plays it out to the wing. Looking for a decent ball in. Saka. And it's played forward. Gabriel Jesus. Gets up to head it. Attempt. Hernandez. It's still a possession this, but very little to show for it. Skriniar plays it forward. Still going. Where to next? Just brushed off the ball there. The ball's come loose and the chase is on. Quick chance at goal. It's gone a long way up and away. Oh, great! That's a hit! Oh, that is very close. That's a great effort. It was very little back here to indicate what was coming. Gabriel Jesus loses his balance and loses the ball. Saka, already of course on the score sheet, hit long and direct. Dembele. Hernandez. Looking to hit the front line. That's been levered clear. Let's put a stop to that. It's the switch to play. Things interesting. him. Is the shot on? Johnson goes back. He's gone for goal. Hernandez can get it clear. And a shot. That has certainly tested the keeper. Oh, that's a sparkling save. Absolutely sparkling. His reflexes were ultra sharp. Paris Saint-Germain pushed both. This has got that foul. That's a foul. Yeah, the referee's given it. He's gone for it. That has been cleared. Gabriel Jesus, laid down the flank. He's got options in the box if he gets his head up. Shakes to shoot. Took too long. Hakimi. Through the first period, and it's looking quite a game here. It's Dembele. Can't get the better of his opposite number. Saka. Hoists it forward. Saka. Not be bit of skill. He's making good use of his strength there. Just refuses to be out-muscled. Ninja averted for now. Zinchenko. It has got through to him. It's broken loose. Dembele. Good defending there. They slammed the door in the faces of the opposition. Gabriel Jesus. It's Gabriel Jesus! Gabriel Jesus. Dembele. Gabriel Jesus. Saka. It's a throw. That's one way of trying to make things happen. There's a few who could follow that example. And it's played forward. They've got it back as soon as they gave it away. That's a hit! Oh, they really should have been made. They've played it short. Zinchenko. Has a goal! It's a carbon copy of the previous. Jesus. Back into the middle. Saka. Gabriel Jesus. Gabriel Jesus!
plates and screws. Very good. Plates and screws. So there was one thing that is asked regarding the application of POP for both modes for arm fracture. Both modes for arm fracture. In which position you apply the POP? As you know the principles of application of POP, you have to immobilize the joint above the fracture in the joint below or distal to the fracture. So here in case of forearm fracture, you have to immobilize the elbow as well as wrist. In which position will you immobilize? If the fracture of the both modes forearm is proximal, you will immobilize it in supination. If it's distal, you will immobilize it in pronation. And if it's the middle, you keep it in mid-throw position. Okay, so immobilize. If the fracture of the both bones forearm is proximal, you will immobilize it in supination. If it's distal, you will immobilize it in pronation. And if it's the middle, you keep it in mid-throw position. Okay, so this position is basically to do with preventing deformity because of muscular pull. You just need to remember the position of application of the POP in the forearm fractures. Moving on to this injury. What do you think this injury is? What is this image? This is an X-ray, right, of the forearm. Very good. Which bone do you think is fractured? Ulna is clearly fractured because how do you identify ulna? First of all, it in the forearm, the fracture. So here it is asked regarding the application of POP or both bones forearm fracture. Both bones forearm fracture. In which position do you apply the POP? As you know the principles of application of POP, you have to immobilize the joint above the fracture in the joint below or distal to the fracture. So here in case of forearm fracture, you have to immobilize the elbow as well as the wrist. In which position will you immobilize? If the fracture of the both bones forearm is proximal, you will immobilize the joint. Screws. Very good. The plates and screws. So there was one MCQ that is asked regarding the application of POP for both bones forearm fracture. Both bones forearm fracture. In which position will you apply the POP? As per the principles of application of POP, you have to immobilize the joint above the fracture in the joint below or distal to the fracture. So here in case of forearm fracture, you have to immobilize the elbow as well as wrist. In which position will you immobilize? If the fracture of the both bones forearm is proximal, you will immobilize it in supination. If it's distal, you will immobilize it in pronation. And if it's the middle, you keep it in mid-throw position. Okay, so this position is basically to do with preventing deformity because of muscular pull. You just need to remember the position of application of the POP in the forearm fractures. Now moving on to this injury. What do you think this injury is? What is this image? This is the X-ray, right, of the forearm plane. Which bone do you think is fractured? You need to remember the position of application of the POP in the forearm fractures. Now moving on to this injury. What do you think this injury is? What is this image? This is the X-ray, right, of the forearm plane. Which bone do you think is fractured? Ulna is clearly fractured because how do you identify ulna? First of all, it has a small brace at the wrist, does not participate at the wrist, and is the one that is articulated with the humerus. And another important thing is the radial head is actually dislocated. It's not in front of the capitulum where it is supposed to be. Instead, it's actually dislocated, which means the small brace at the wrist does not participate at the wrist, and is the one that is articulated with the humerus. What is this image? This is an X-ray, right, of the forearm. Very good. Which bone do you think is fractured? Ulna is clearly fractured because how do you identify ulna? First of all, it has a small brace at the wrist, does not participate at the wrist, and is the one that is articulated with the humerus. And another important thing is the radial head is actually dislocated. It's not in front of the capitulum where it is supposed to be. Instead, it's actually dislocated, which means the proximal radial ulnar joint is disrupted. Proximal radial ulnar joint is disrupted. This is Montagian fracture. It is a fracture in a dislocation combination. What is a fracture? The fracture of ulna with the radial head dislocation, or also known as proximal radio-ulnar joint disruption. Proximal radio-ulnar joint disruption. And clearly see there is disruption. Okay, alright, clear enough? Right. Now there is a classification for Montagian fracture. Very, very important fracture for us. Very, very important. What is the classification? Bado classification. This is Montagian fracture. It is a fracture in a dislocation combination. What is the fracture? The fracture of ulna with the radial head dislocation, or also known as proximal radio-ulnar joint disruption. Proximal radio-ulnar joint disruption. You clearly see there is disruption. Okay, alright, clear enough? Right. Now there is a classification for Montagian fracture. Very, very important fracture for us. Very, very important. What is the classification? Bado classification. Disruption. Proximal radio-ulnar joint disruption. You clearly see there is disruption. Okay, alright, clear enough? Right. Now there is a classification for Montagian fracture. Very, very important fracture for us. Very, very important. What is the classification? Bado classification. Bado disruption. Proximal radio-ulnar fracture. It is a fracture in a dislocation combination. What is a fracture? The fracture of ulna with the radial head dislocation, or also known as proximal radio-ulnar joint disruption. Proximal radio-ulnar joint disruption. You clearly see there is disruption. Okay, alright, clear enough? Right. Now there is a classification for Montagian fracture. Very, very important fracture for us. Very, very important. What is the classification? Bado classification. Bado classification. And what is the classification? There are 4 types. Type 1, type 2, type 3, and type 4. In all the types, one thing is for sure common. All of them have ulnar fracture. All of them have ulnar fracture. 1, 2, 3, type 1 and ulnar fracture. What is the difference? In type 1 below, ulnar fracture with radial head dislocation. Type 2 ulnar fracture with radial head dislocation. Type 3 ulnar fracture radial head dislocation. Type 4 ulnar fracture radial head dislocation. मतलब radial head dislocation is also a common thing among all of them. So type 1, 2, 3, 4, what is the similarity? Ulnar fracture with radial head is dislocated. Then what is the difference? Very simple. In type 1, radial head is dislocated anteriorly. In type 2, radial head is dislocated posteriorly. In type 3, radial head is dislocated laterally. Now what about type 4? In type 4, radial head is dislocated anteriorly and there is a fracture of the radius. Okay? So most of the times the MCQs are asked based on type 1 and type 2. Why? Type 1 is the most common type. Type 1 is the most common type. Ulnar fracture with the radial head dislocation and proximal radial joint disruption. When the radial head dislocates out anteriorly. Okay? So this is it. Proximal radial joint disruption or dislocation with a fracture. In all of them, ulnar is fractured and radial is dislocated, but it is dislocated anteriorly in type 1, posteriorly in type 2, laterally in type 3, anteriorly with a fracture of radius in type 4. Type 1 and type 2 is what I want to remember. Now tell me, based on the algorithm, what is the treatment of Montefiore fracture? Montefiore fracture, Valency fracture, they are fractures of necessity, right? So you have to go for open reduction with a fracture of radius in type 4. Type 1 and type 2 is what I want to remember. Now tell me, based on the algorithm, what is the treatment of Montefiore fracture? Montefiore fracture, Valency fracture, they are fractures of necessity, right? So you have to go for open reduction anteriorly with a fracture of radius. Type 1 and type 2 is what I want to remember. Now tell me, based on the algorithm, what is the treatment of Montefiore fracture? Montefiore fracture, Valency fracture, they are fractures of necessity, right? So you have to go for open reduction anteriorly with a fracture of radius in type 4. Type 1 and type 2 is what I want to remember. Now tell me, based on the algorithm, what is the treatment of Montefiore fracture? Montefiore fracture, Valency fracture, they are fractures of necessity, right? So you'll have to go for open reduction, internal fixation with plates and screws. And which bone will you plate? You will plate ulnar, because that is the one that is fractured. And usually by plating ulnar, the proximal radial ulnar joint is stabilized. If not, you can put a K-bands. Valency fracture, they are fractures of necessity, right? So you'll have to go for open reduction, internal fixation with plates and screws. And which bone will you plate? You will plate ulnar, because that is the one that is fractured. And usually by plating ulnar, the proximal radial ulnar joint is stabilized. If not, you can put a K-bands stabilized. Another MCQ that frequently asked is, which is the most commonly injured nerve in Montefiore fracture? If you look carefully, in Montefiore fracture, the radial head is dislocated, right? The radial head is dislocated, and when it is dislocating, the nerve that wraps around the radial head and neck, that nerve will get injured. Which nerve is that? Which nerve is that? Tell options, please choose one. Is it sciatic nerve, femoral nerve, popliteal nerve, or posterior interosseous nerve? Yes, right. It is posterior interosseous nerve is the branch of radial nerve, right? So the most common injured nerve is posterior. Which nerve is that? Tell options, please choose one. Is it sciatic nerve, femoral nerve, popliteal nerve, or posterior interosseous nerve? Yes, right. It is posterior interosseous nerve is the branch of radial nerve, right? So the most common injured nerve is posterior interosseous nerve. And if you recall from nerve injuries, what happens in posterior interosseous nerve injury or pin palsy? The patient will have finger drop, thumb drop, but the patient will not have any sensory loss and his step function will be fine. The step function will be very good. Now, while the topic of the nerve that are injured, can you tell me what is the most common injured nerve in shoulder dislocation? We just said it. Thumb drop, but the patient will not have any sensory loss and his step function will be fine. This extension will be very good. Now, while the topic of the nerve that are injured, can you tell me what is the most common injured nerve in shoulder dislocation? We just said it. Excellent, very good. And it's supraorbital humerus fracture. Anterior interosseous nerve more than median. Beautiful, beautiful. So look at this patient. The patient has a ulnar fracture with a proximal radial ulnar joint disruption or radial head dislocation. This is Montefiore fracture, and we have plated ulnar nicely over here. Okay, now look at this image and tell me the diagnosis. Which one is fractured? This is radius. The one with the broad base, and this is ulnar. It looks clearly like there is a radius fracture with distal radial ulnar joint disruption. Radius fracture with distal radial ulnar joint disruption. This is your Galeazzi or BMO or reverse Montefiore fracture. Alright, so it's a radius fracture with the distal radial ulnar joint disruption, and I've told you distal radial ulnar joint is stabilized by something known as TFCC or triangular fibrocartilage complex. Triangular fibrocartilage complex, and once the DRUG is disrupted, triangular fibrocartilage complex will be disrupted. So in other words, what is Galeazzi fracture? Galeazzi fracture is a fracture of the radius with DRU, triangular fibrocartilage joint disruption is known as fracture. This is radius, the one with the broad base, and this is ulnar. It looks clearly like there is a radius fracture with distal radial ulnar joint disruption. Radius fracture with distal radial ulnar joint disruption. This is your Galeazzi or BMO or reverse Montefiore fracture. Alright, so it's a radius fracture with the distal radial ulnar joint disruption, and I've told you distal radial ulnar joint is stabilized by something known as TFCC or triangular fibrocartilage complex. Triangular fibrocartilage complex, and once the DRUG is disrupted, triangular fibrocartilage complex will be disrupted. So in other words, what is Galeazzi fracture? Galeazzi fracture is a fracture of the radius with DRUG disruption or radius fracture with TXCC injury. Again, this is the fracture of necessity, which requires you to openly reduce and internally fix the radius, and DRVJ will be stabilized. Okay? Readouts. Next, look at this image. Radius fracture with TXCC injury. Again, this is the fracture of necessity, which requires you to openly reduce and internally fix the radius, and DRVJ will be stabilized. Okay? Readouts. Next, look at this image. Again, this is an image of forearm. And it looks like the radius is fine, but there is a fracture of ulna. Is it pontifical fracture? Ulna fracture with radial head dislocation. But radial head is not dislocated. It's nicely sitting under the capitulum. So there is an isolated ulna fracture. What is this? This is a nightstick fracture. And why is it called nightstick fracture, my friends? It's because the danda of the policeman will hit you, right? So how? So when somebody hits you with a stick, or if a policeman is hitting you with a stick or danda, how do you defend yourself? You defend yourself like this. Right? You defend yourself like this. And if you defend yourself like this, the stick comes and hits you over here. If a policeman being hit, the head is not dislocated. It's nice. And how? So when somebody hits you with a stick, or if a policeman is hitting you with a stick or danda, how do you defend yourself? You defend yourself like this. Right? You defend yourself like this. And if you defend yourself like this, the stick comes and hits you over here. The fracture is called ulna. So isolated ulna fracture is called nightstick fracture, suggestive of a self-defense injury. Self-defense injury. Is that clear? And based on our algorithm, you will know the treatment of isolated ulnar fracture. You can go for POP or open internal fixation with plates and screws. Wonderful, wonderful. Now, what the self-defense injury? Is that clear? And based on our algorithm, you will know the treatment of isolated ulnar fracture. You can go for POP or open internal fixation with plates and screws. Wonderful, wonderful. Now, what is the diagnosis of this fracture? Chalo, pause and tell me the answer.
Condylgia fracture.
Yeah, it's fracture and radial head is dislocated. Is it anterior dislocation or posterior dislocation? Anterior dislocation. So, what about type 1? So, it is Montague fracture type 1. Very good. Now, is injured. That is posterior interosseous nerve is injured in posterior dislocation.
Montague fracture.
Reverse Montague fracture. Montague fracture. Supracondylar humerus fracture. Sure.
Montague fracture.
Very good. The answer is Montague fracture. Because in posterior dislocation of elbow, which nerve will get injured? Ulnar nerve. Very good. In supracondylar humerus fracture, it is anterior interosseous nerve more than median nerve. Very good. And in Montague fracture, it is in pulse. Your answer is Montague fracture. Because in posterior dislocation of elbow, which nerve will get injured? Ulnar nerve. Very good. In supracondylar humerus fracture, it is anterior interosseous nerve more than median nerve. Very good. And in Montague fracture, it is pin palsy. It is pin palsy. Now, once we are done with forearm fractures, let's move on to the distal end of the radius fractures. Distal end of the radius, very important area. A lot of fractures happen here. Distal end of the radius fractures. Now, the distal end of the radius fractures have an interesting story. They were described by this gentleman, Dr. Abraham Police. And to study the distal end of the radius fractures, what this gentleman did was he actually used dead bodies. He used the dead bodies and made them fall in a particular way to understand which type of injury. Distal end of the radius fractures have an interesting story. They were described by this gentleman, Dr. Abraham Police. And to study the distal end of the radius fractures, what this gentleman did was he actually used dead bodies. He used the dead bodies and made them fall in a particular way to understand which type of injury caused which fracture. It was very interesting what he did. Okay, so there are various fractures that occur at the distal end of the radius. There is Police fracture, based on his name, Smith's fracture, Barton's fracture, and Schoeffer's fracture. Now tell me, just imagine, which one will be the most common fracture? Obviously the one with his name, right? So Police fracture is the most common fracture of the distal end of the radius. So please understand that Smith's fracture, Barton's fracture, and Schoeffer's fracture. Now tell me, just imagine, which one will be the most common fracture? Obviously the one with his name, right? So Police fracture is the most common fracture of the distal end of the radius. So please understand that this is the shaft of the radius, right? And this is the distal end of the radius. So what type of bone will you find at the distal end of the radius? Cortical or cancellous? So mostly cortico-cancellous junction, right? That is the junction, cortico-cancellous junction. So mostly cancellous bone. So cortico-cancellous junction fractures are your distal end of the radius fractures. So there are Colles, Smiths, Bartons, and Schoeffers. And it is your job to differentiate between all of them because I've told you, clinical subject है, diagnosis is important. So in order to diagnose all of these fractures, because if you don't diagnose them properly, they will end up looking the same way. Okay, all of them will appear almost the same way and it's confusing. So we have to understand the normal anatomy first, and only then we can appreciate what the fracture is. So this is the anatomy of your breast, exhale, epithelium, and this is the lateral view. What do you see? This is the radius, and this is the ulna, right? This is the articular surface of the radius. Epithelium. What do you notice? You notice the articular surface of the radius is actually pointing towards the ulnar side of the hand. It's pointing towards the ulnar side of the hand in epithelium. Very good. And in lateral view, what do you notice? Right? This is the artery. First, and only then we can appreciate what the fracture is. So this is the anatomy of your breast, exhale, epithelium, and this is lateral view. What do you see? This is the radius, and this is the ulna. Right? This is the articular surface of the radius. What do you notice? You notice the articular surface of the radius is actually pointing towards the ulnar side of the hand. It's pointing towards the ulnar side of the hand in AP. Very good. And in lateral view, what do you notice? You notice that the articular surface of the radius is pointing towards the volar side, EY side. This is called volar or palmar or anterior or ventral. Volar, palmar, anterior or ventral. And what is the surface? This is dorsal or posterior. This is posterior, so anterior. So if you look at the distal of the radius, it is pointing towards the volar, palmar, ventral, anterior surface. Now in an X-ray, you will not know what is anterior or posterior unless you look for a landmark. The landmark here is thumb. The metacarpal of the thumb, anterior. So anterior. So if you look at the distal of the radius, side, volar, EY side. This is called volar or palmar or anterior or ventral. Volar, palmar, anterior or ventral. And what is the surface? This is dorsal or posterior. This is posterior, so anterior. So if you look at the distal of the radius, it is pointing towards the volar, palmar, ventral, anterior surface. Now in an X-ray, you will not know what is anterior or posterior unless you look for a landmark. The landmark here is thumb. The metacarpal of the thumb is on the anterior side. So if the distal of the radius is pointing towards the thumb, then it is normal. Okay, so this is the thumb, this is the metacarpal of the thumb, and the distal of the radius is pointing towards the thumb, then it is normal. Okay, so what are the fractures that can occur at the distal of the radius? The fracture. So if the distal of the radius is pointing towards the thumb, then it is normal. Okay, so this is the thumb, this is the metacarpal of the thumb, and the distal of the radius. The landmark here is thumb. The metacarpal of the thumb is on the anterior side. So if the distal of the radius is pointing towards the thumb, then it is normal. Okay, so this is the thumb, this is the metacarpal of the thumb, and the distal of the radius is pointing towards the thumb, then it is normal. Okay, so what are the fractures that can occur at the distal of the radius? The fractures that can occur at the distal of the radius are extra-articular fractures, because this is the articular surface. Articular surface of extra-articular fracture, or intra-articular fractures. Intra-articular fractures. That is one thing. Another thing that I want to look at is, if you look at the EP, you see this is the distal of the radius. This is the scaphoid, this is lunate. Right? Scaphoid, lunate, and then trapezium and pisiform. Trapezium, trapezoid, capitate and hamate. These are the bones, right? These are the bones, you should know this. So the distal of the radius articulates with scaphoid, lunate and trapezium. These are the bones that make the wrist. Ulnar does not participate in the wrist, first thing. Second thing that you need to know is the hamate. These are the bones, right? These are the bones, you should know this. So the distal of the radius articulates with scaphoid, lunate and trapezium. These are the bones that make the wrist. Ulnar does not participate in the wrist, first thing. Second thing that you need to know is the first or the largest carpal bone. Capitate is the largest carpal bone. Pisiform obviously is the smallest carpal bone. Alright, capitate is the first carpal bone to ossify around 2 months of age. So if you see an X-ray of a 2-month-old baby, you will only see capitate there. When it becomes 3-month-old baby, you will see hamate also. Right? That you know. That you know. Very good. Very good. Now, which is the most commonly fractured carpal bone? I think it is scaphoid, right? Very good. Most commonly dislocated carpal bone is lunate. We'll talk about this in carpals. So let's just focus on the distal of the radius here and not get confused. So whenever you see a distal of the radius and there is a fracture, I want you to follow these steps to make a proper diagnosis. First, see whether the fracture is extra-articular or intra-articular. If the fracture is extra-articular, it is either Colles or reverse Colles. Colles or reverse Colles. Reverse Colles को क्या है? Smith's fracture. It's called Smith's fracture. So extra-articular fracture is either Colles or Smith's fracture. How will you differentiate it? Just look at the distal fragment. Just look at the distal fragment. The distal fragment, if it is dorsally displaced, not the dorsally, means away from the thumb, then it is Colles. If it's ventrally displaced, look in the direction of the thumb, then it is reverse Colles or Smith's fracture. And the reason for this is because of the mechanism of injury. For Colles fracture to occur, the patient would fall on an outstretched hand with wrist in extension like this. So when the patient falls with wrist in extension, the distal fragment goes dorsally. And for Smith's fracture to occur, the patient has to fall like this, which obviously is a very rare type of falling down. Nobody falls like this, we fall like patient would fall dorsally, means away from the thumb. Then it is Colles. If it's ventrally displaced, look in the direction of the thumb, then it is reverse Colles or Smith's fracture. And the reason for this is because of the mechanism of injury. For Colles fracture to occur, the patient would fall on an outstretched hand with wrist in extension like this. So when the patient falls with wrist in extension, the distal fragment goes dorsally. And for Smith's fracture to occur, the patient has to fall like this, which obviously is a very rare type of falling down. Nobody falls like this, we fall like this. So when the patient falls like this, then the distal fragment goes ventrally or volary or palmary, and you get a reverse Colles or Smith's fracture. Intra-articular fractures are your buttons and chauffeurs. We'll talk more about them later. Okay? So this table summarizes extra-articular fractures, intra-articular fractures. Extra-articular fracture with dorsal or ventral displacement. If it's an extra-articular fracture with dorsal displacement, it is Colles. If it's an extra-articular fracture with ventral displacement, it is Smith's. What is Barton's fracture? Barton's fracture is an intra-articular. Yes, but it's not only a fracture. It is a fracture with carpal subluxation. So carpal subluxation. Buttons is intra-articular with carpal subluxation. What do you mean carpal subluxation? You see the lateral view. The radius, not only a fracture. It is a fracture with carpal subluxation. So carpal subluxation. Buttons is intra-articular with carpal subluxation. What do you mean carpal subluxation? You see the lateral view. The radius, lunate, capitate. Right? These are the bones. They are in a straight line. Carpal subluxation means carpals move. With the fracture, carpals also move. I'll show you that, don't worry about it. So Gordon's fracture is intra-articular fracture with carpal subluxation, whereas chauffeur is only the radial styloid fracture. Only a radial styloid fracture. Everything will make sense. You just endure for some time and everything will make sense. So let's look at this image now. This is an X-ray of the wrist APM, lateral view. In APM, you can clearly see that there is a fracture. Intra-articular, extra-articular, extra-articular. Wonderfully. So everything will make sense. You just endure for some time and everything will make sense. So let's look at this image now. This is an X-ray of the wrist APM, lateral view. In APM, you can clearly see that there is a fracture. Intra-articular, extra-articular, extra-articular. Wonderfully. Radius, very good. Now this is lateral view. You can see that there is an extra-articular fracture. But the first thing you should do is identify whether an X-ray of the wrist APM, lateral view. In APM, you can clearly whereas chauffeur is only the radial styloid fracture. Only a radial styloid fracture. Everything will make sense. You just endure for some time and everything will make sense. So let's look at this image now. This is an X-ray of the wrist APM, lateral view. In APM, you can clearly see that there is a fracture. Intra-articular, extra-articular, extra-articular. Wonderfully. Radial fracture. Everything will make sense. You just endure for some time and everything will make sense. So let's look at this image now. This is an X-ray of the wrist APM, lateral view. In APM, you can clearly see that there is a fracture. Intra-articular, extra-articular, extra-articular. Wonderfully. Everything will make sense. You just endure for some time and everything will make sense. So let's look at this image now. This is an X-ray of the wrist APM, lateral view. In APM, you can clearly see that there is a fracture. Intra-articular, extra-articular, radial styloid fracture. Only a radial styloid fracture. Everything will make sense. You just endure for some time and everything will make sense. So let's look at this image now. This is an X-ray of the wrist APM, lateral view. In APM, you can clearly see that there is a fracture. Intra-articular, extra-articular, extra-articular. Wonderful. Radius, very good. Now this is lateral view. You can see that there is an extra-articular fracture. But the first thing you should do is identify where the thumb is. Thumb is carpal is here. So this is the radius is facing away from the thumb or towards the thumb? Away from the thumb. So this is extra-articular dorsal displacement Colles fracture. Very good, very good. Again, practice. Extra-articular fracture. Extra-articular fracture. Distal articular surface. This is thumb. Facing away from the thumb, this is Colles fracture. Very good, right. So this is the radius, corticocancellous junction, extra-articular fracture, common in elderly post-menopausal females following on outstretched hand with wrist extension. If they fall with wrist inflection, they get Smith's fracture. Now, the MCQs are based on their displacements. What are the displacements? I just told you, it's dorsally displaced and laterally displaced. So dorsal, lateral, very, very important. Dorsal and lateral. Dorsal and lateral. And this gives you the classical Dinner fork deformity. Classical, it's dorsally displaced and laterally displaced. So dorsal, lateral, very, very important. Dorsal and lateral. Dorsal and lateral. And this gives you the classical Dinner fork deformity. Classical Dinner fork deformity. Elderly, following an outstretched hand, comes to with the Dinner fork deformity. The first thing that should come to your mind. Colles fracture. Very good. The classical Dinner fork deformity. Classical Dinner fork deformity. Elderly, following an outstretched hand, comes to with the Dinner fork deformity. The first thing that should come to your mind. Colles fracture. Very good. Okay, now look at this. Colles fracture is associated with all except common fracture in postmenopausal elderly people. Yes. Posterolateral displacement of the distal fragment, posterior dorsal and lateral displacement. Yes. Impaction and shortening. Yes, there is impaction of the fracture. Very good. Posteromedial displacement. Posteromedial. No. It's posterolateral. So this is the wrong statement. Alright. So what is the treatment of Colles fracture? Based on our algorithm, it's an upper limb extra-articular fracture. So close reduction, POP application can be done, but the definitive treatment would be open reduction, internal fixation with plates and screws. Right. So close reduction, wrong statement. Alright. So what is the treatment of Colles fracture? Based on our algorithm, it's an upper limb extra-articular fracture. So close reduction, POP application can be done, but the definitive treatment would be open reduction, internal fixation with plates and screws. Right. So this is the wrong statement. Alright. So what is the treatment of Colles fracture? Based on our algorithm, it's an upper limb extra-articular fracture. So close reduction, POP application can be done, but the definitive treatment would be open reduction, internal fixation with plates and screws. Right. So close reduction, POP application can be done, and the POP is applied in hand shaking position. In which position? Hand shaking position or the hand shaking. POP application can be done, but the definitive treatment would be open reduction, internal fixation with plates and screws. Right. So close reduction, POP application can be done, and the POP is applied in
thoracic compression, palmar flexion.
Hand shaking position. In which position? Hand shaking position or the hand shaking cast. The cast used in the police fracture is hand shaking cast. Actually, it's not this hand shaking cast, it's actually this hand shaking, proper hand shaking, which people present their hands to the kiss now. So there is palmar flexion and ulnar deviation, this kind of position. This is known as hand shaking casting. Or you can go for surgery, open traction, internal fixation with plates and screws. Okay, the proper hand shaking, which people present their hands to the kiss now. So there is palmar flexion and ulnar deviation, this kind of position. This is known as hand shaking casting. Or you can go for surgery, open traction, internal fixation with plates and screws. Okay, that's the treatment of Colles fracture. Look at this now. An old lady slept and fell at home. She was diagnosed with a Colles fracture and managed with a POP cast. Okay, what is the correct sequence of reduction? So before you apply the POP cast, you have to reduce, and then you apply the POP cast. The question is asking, what is the sequence of reduction? We know the displacements. The displacement of dorsal detention, impaction, lateral detention, and swingation. That's the displacement. Now, how will you correct the displacement? This is quarter fraction. So reduce and then you apply the POP cast. The question is asking, what is the sequence of reduction? We know the displacements. The displacement of dorsal detention, impaction, lateral detention, and supination. That is the displacement. Now, how will you correct the displacement? This is the order of correction. First, you will give traction. Very good. We'll give traction, and then what will you do? You'll do palmar flexion and ulnar deviation. Palmar flexion and ulnar deviation. So the correct answer here is B. That is the step of reduction. If you did not understand, don't worry. I will show you a video of reduction of Colles fracture. If you want your internship, you must have seen your resident suit. Now here I would like to demonstrate this deformity which is in front of you. This is your clear deformity where there is a swelling around the wrist. This is an elderly patient, history of fall on an outstretched hand. This is your inner fork deformity. Now this is from another angle where you can clearly see a lateral view showing you the classical inner fork deformity of your Colles fracture, which is an extra-articular fracture of the distal end of the radius. And this is the X-ray of the gentleman trying to show you that there is an extra-articular fracture of the distal end of the radius. And in AP view you can clearly see it's an extra-articular fracture. And in lateral view also you can clearly see it's an extra-articular fracture with the distal fragment dorsally displaced. Now, can you quickly recall and tell me what were the deformities or the displacements seen in Colles fracture? There was a dorsal tilt and shift, there was a lateral tilt and shift, there was an impaction, and there was a supination. So the technique of reduction of Colles fracture is basically to counteract or to reduce the fracture in the opposing direction of the displacements that I've just talked about. So dorsal, we need to bring it to volar, and impaction means we need to give traction to reduce the impaction, and lateral deviation means it's radial deviation, so we need to bring it towards the ulnar side, and if it's in supination, we need to bring it into pronation. So let me show you the steps of reduction of Colles fracture. So here there are three people, you know what is being done here. This gentleman over here is providing the traction, that gentleman over there at the end is providing the counter traction, and this gentleman right in the middle is the one basically trying to mold and reduce the fracture into the desired form that we want. So traction is being applied here to reduce which type of deformity? The impaction, right? So to reduce the impaction, we need to give traction. And you can obviously see that the forearm is in pronation already because the supination was the deformity, and so they are bringing the distal fragment into pronation. So pronation is being taken care of by rotating the forearm. So what are we reducing? We are reducing the supination. Traction being provided to basically reduce the impaction. So impaction is being taken care of, supination is being taken care of by traction and pronation. What are the two things we need? So we need to do palmar flexion to counteract the dorsal tilt, and we also need to do ulnar deviation to correct the lateral shift and tilt. So what else do we need? We need palmar flexion and ulnar deviation. You can clearly see that the doctor in the middle is basically trying to reduce the fracture, while the person providing the traction is giving palmar flexion as well as ulnar deviation. You can clearly see that he's giving palmar flexion now and also ulnar deviation. Now you can see that the doctors over here are holding the wrist in palmar flexion as well as fracture, while the person providing the traction is giving palmar flexion as well as ulnar deviation. You can clearly see that he's giving palmar flexion now and also ulnar deviation. Now you can see that the doctors over here are holding the wrist in palmar flexion as well as ulnar deviation, and the cast padding or the soft coat has already been applied. Now they are putting the POP slab, that is calcium sulfate hemihydrate, mixed with water becomes calcium sulfate dihydrate, and they will apply it on the dorsal aspect of the wrist so that the dorsal tilt does not happen and the POP acts as a buttress preventing. Now they are putting a POP slab, that is calcium sulfate hemihydrate, mixed with water becomes calcium sulfate dihydrate, and they will apply it on the dorsal aspect of the wrist so that the dorsal tilt does not happen and the POP acts as a buttress preventing it from displacing dorsally. Then all the while that he's applying it, the body will remove sulfate dihydrate and they will apply it on the dorsal aspect of the wrist so that the dorsal tilt does not happen and the POP acts as a buttress preventing it from displacing dorsally. Then all the while that he's applying it, the body will remove the traction and the reduction because it will otherwise go back into displacement. Now the cotton roll or the gauze roll or the roller bandage is being displacing dorsally. Then all the while that he's applying it, the body will remove the traction and the reduction because it will otherwise go back into displacement. Now the cotton roll or the gauze roll or the roller bandage is being applied to keep the slab in place. Now the doctor is molding the POP to keep the fracture reduced after application of the cotton or the soft roll. And this is the final casting that you can see. This is your hand shaking cast with pronation, ulnar deviation and flexion applied to the wrist. These are the techniques of reduction of Colles fracture. So remember, traction is applied, pronation is done, palmar flexion is final casting that you can see. This is your hand shaking cast with pronation, ulnar deviation and flexion applied to the wrist. These are the techniques of reduction of Colles fracture. So remember, traction is applied, pronation is done, palmar flexion is done, casting that you can see. This is your hand shaking cast with pronation, ulnar deviation and flexion applied to the wrist. These are the techniques of reduction of Colles fracture reduced after application of the cotton or the soft roll. And this is the final casting that you can see. This is your hand shaking cast with pronation, ulnar deviation and flexion applied to the wrist. These are the techniques of reduction of Colles fracture. So remember, traction is applied, pronation is done, palmar flexion is done and ulnar deviation is done. And the POP is applied in hand shaking position. It's not this typical hand shaking position. It's pronation, ulnar deviation and palmar flexion. This is this hand shaking position and that is the cast applied. And remember, it is always below elbow because we all know that the most common complication is the stiffness of the fingers. And we do not want that stiffness of the fingers. It also causes the stiffness of the wrist at the elbow. So the cast is a below elbow cast. So to summarize, the sequence of reduction is traction, palmar flexion, ulnar deviation, and once it is reduced, you apply the plaster of Paris below the elbow. Right. Now, position of the wrist in Colles cast is, what is the position of the wrist in the Colles cast? Hand shaking position. Is it dorsal deviation and supination? Is it dorsal deviation and pronation?
Nah.
Is it palmar deviation and supination? Or is it palmar deviation and pronation? Yes, it's palmar deviation and pronation. This is the correct answer. That is the position. That is the position. Now, what are the complications of this Colles fracture? Very simple. Stiffness is actually the most common complication, but unfortunately, I have never seen this on an MCQ exam. Second most common complication is the one that they usually show you in small union, and the deformity is integral fold deformity. Other interesting complication is complex regional pain syndrome, also wrist psoas dystrophy. Here what happens is because of the fracture, the nerve is injured, and because of the injury of the nerve, there is a parasympathetic-sympathetic mismatch. That is autonomic nervous system mismatch. And because of this, the patient will have a tense swelling, paresthesia, tingling, and numbness, shiny skin profile. Here what happens is because of the fracture, the nerve is injured, and because of the MCQ exam. Second most common complication is the one that they usually show you in small union, and the deformity is inner fork deformity. Other interesting complication is complex regional pain syndrome, also wrist psoas dystrophy. Here what happens is because of the fracture, the nerve is injured, and because of the injury of the nerve, there is a parasympathetic-sympathetic mismatch.
this is proving to be a very good spell. The intensity is great, but they've got to make it count.
Trying to sell the kids, but today we have. I really wish I was joking.
Jensen, you know, first of all, I want to, sorry.
To sort of mine.
They're not going to your part. Whoa.
KSI and Logan have responded to the Lunchley drama yet again, and this is by far the worst response yet. Basically, if you missed the last video, they were having these crybaby meltdowns after Dan TDM called them out for the new product Lunchley, which is some ultra-processed food that they're trying to sell to.
Doing that, I guess how it gets so slow, you love someone and then let you go. Don't you let it kill you, even way just like him. break it. Even Alex Valle, Eric García,
Abre muy bien la defensa con este pase. Lewandowski.
Lewandowski.